Good morning, ladies and gentlemen. The topic of my today's lecture is from the section of aesthetic dermatology from Rook, chapter 158. And this is about soft tissue augmentation by fillers. I've tried not to add anything from my side in this talk because I want to keep this talk as truly academic as seen by Rook textbook of dermatology. Introduction. Initially, the indications for dermal filler use was to diminish and efface the skin wrinklings and folds. This was how the dermal fillers were invented and the use started. But with the advent of fillers designed for very superficial use as well as for deep volume augmentation, the indications have expanded substantially. There are now a multiple of injectable fillers available in the international marketplace. Indications. The first indication is to improve the skin quality. When the skin ages, particularly in skin type 1 and 3, the skin becomes atrophic with fine wrinkles. And the injectable fillers not only improves the atrophy and wrinkles, but it also improves the skin quality. Wrinkles and folds. This remains the primary indication for all the injectable fillers. Volumizing. Facial aging results in reduction in size of facial fat pad with resultant positional shifting and malalignment causing an aged facial phenotype, even in those with high body mass index. So obesity is not a requirement that the facial skin will remain smooth, but as the age advances, not only the fat pad they get reduced. Sometimes they are hypertrophied, the ligament get lax, and there is bone atrophy, all resulting in sagging. The natural and convincing replenishment of lost volume is a skill that requires accurate patient assessment and proficient aesthetic judgment. So, all the filler treatment starts from the good assessment. And this assessment is a skill you have to learn with repeated conferences, trainings, etc. The challenge is smart filling in the areas that will have the most visual impact. Overcorrection of volume looks artificial and should be avoided. So, this smart filling is also a trick which is to be learned. The goal is less concavity but not an overblown face. So a female face have convex outlines, while male face have flattish outlines. So no face is looks good if it is concave. So not only the concavity should be filled, but it should not be overfilled to look bloated. This is particularly relevant for men where volume loss in the cheek should only be gradually corrected. In general, young skin is easier to correct compared with older skin, where elastosis limit volumization. And furthermore, as the age advances, the dermis becomes thin and it is unable to hold the fillers which are placed beneath the dermis or in the subcutaneous tissue. So always the results of aesthetic treatment, especially with fillers, is best in 40s and early 50s as compared to later ages. Techniques. Fillers are injected both by needles as well as by cannulas. The discussion about which is the best is sometimes more dogmatic than scientific. The location of product placement remains more important than method to deliver it. A good aesthetic physician knows how to inject both with cannulas as well as with needles. There are clear indications for use of needle for more superficial cutaneous lines and deposition of filler over the bone, whereas the cannulas are best suited for widespread of fillers in the subcutaneous or subdermal planes. Evidence demonstrating that cannula technique is safer than use of needle is scarce, although the theoretical risk of penetration of a vessel with resultant embolization and vascular compromise seems to be reduced when we are using the blunt cannula of size 25G or above compared to sharp needles. There is less chances of hematoma formation and redness with cannula use as compared to needles, and less reported pain. Of great importance is that the injector must stick to the tool he/she feels comfortable with. The depot and fanning techniques. There are two basic techniques used for injection of a dermal filler. One is the depot technique, where drops of various sizes are injected in the areas that need filling, that need volumization, especially over the bone. That is by tower technique. And the fanning is a technique when some effect come from the needles or cannula dissecting the subcutaneous area, and you can spread the filler in subcutaneous plane by a single entry point in a larger area. You can spread the filler by fanning technique. So if we compare the needles as well as cannulas, for volume deficit, both cannula and needles will be used. To fill the folds and deep wrinkles, both cannula and needles are to be used. For fine wrinkles, cannula are not effective. We have to use the needles. And for the dermal restoration, again, the needles are to be used. Now we are going to discuss the different kinds of fillers. The first are the biodegradable fillers. The biodegradable fillers are non-permanent fillers, currently dominated by hyaluronic acid products or HA fillers. Collagen fillers are not currently available in most markets, and calcium hydroxyapatite and polycarbolactone are less commonly used. We will describe these two fillers as well. The biodegradable fillers can be grouped into those that are inert and those causing collagen stimulation like PLLA. The inert fillers act in a similar fashion. However, there is one product group which has an antidote, and that is a hyaluronic acid filler. The antidote of hyaluronic acid fillers is hyaluronidase. Hyaluronic acid-based fillers. Hyaluronic acid fillers are overwhelmingly the most popular type of product used for its long-lasting effects, low allergic potential, and improved safety profile due to the ability to reverse effects with the use of hyaluronidase. The presence of hyaluronidase, which is the antidote of hyaluronic acid, is the safety of hyaluronic acid fillers. That's why these fillers are preferable in most circumstances. Products vary in concentration of hyaluronic acid, the particle size, the cross-linking, the gel consistency, and the hardness. The arena is further confused by vast number of hyaluronic acid fillers available and fast pace of product evolution. The HA product with longest history of use is Restylane of Nasha family. A completely different HA product previously called as the Emerville is distributed with the name of Restylane with addendum OBT. The Restylane Perline, which is now the Restylane Lift, perform similar or slightly less well than Restylane Define. Another family of filler which is FDA approved is Juvederm. It includes the Juvederm Voluma, Volbella, Volift, Volite for different type of lines and wrinkles as well as for volumizing. Another FDA approved filler is the Bellatero range. So these are the fillers which are FDA approved, and most of them are US based companies. There are several fillers which are available in our market which are European CE accredited. So these CE marked fillers are also well reputed, and you can consider them as good fillers because these are marked by the European health authorities. The safety profile of hyaluronic acid is improved due to the availability of high hyaluronidase. This is a soluble protein enzyme capable of degrading HA. These are used therapeutically to reverse the effects of inappropriate placements, overcorrections, or adverse events associated with HA such as nodules or inflammation. The use of hyaluronidase is essential in emergency situations such as vascular occlusions or embolization from HA filler. The local injection site reaction may occur with hyaluronidase, including redness, edema, pruritus, pain, which are immediate and delayed allergic reactions. But since these fillers are this solution is used in emergency, we can get away with these mild effects to counter the more serious adverse events. The non-hyaluronic acid-based fillers. All other available biodegradable fillers lack the antidote. This is, of course, a clear disadvantage which needs to be considered carefully while choosing a filler. That is why we always advise the beginners to use hyaluronic acid-based fillers. Once you are proficient in injection, then you can try the other non-HA based fillers of who those the antidotes are not available. So one of the very popular non-HA based filler is calcium hydroxyapatite, also known as the KAHA. It's a whitish material made from synthetically formed calcium phosphate pearls mixed with lidocaine to reduce the injection pain. Early studies focused on correction of drug-induced lipoatrophy in patients of HIV. KAHA is considered to be superior compared with human collagen in 6-month study. But the two 12-month comparison studies with HA fillers did not show any clear advantage of KAHA over HA. The patient preference and satisfaction with treatment favored KAHA. The best place to use KAHA over bone for structural change. It is not used for tear trough and nasolabial fold as mentioned in Rook. But I am not sure if you will find an MCQ mentioning the use of KAHA in tear trough and nasolabial fold, which is mentioned in Rook. But this filler is not to be used in these settings. Sodium alginates is a sodium salt of alginic acid, which is a polymeric polysaccharide. Redness, swelling, and even hematoma seem to be less prevalent compared with HA products. This is some unpublished data, and it is quite easy to inject. However, the subsequent adverse events such as nodule formation are reported, specifically in areas such as infraorbital hollows. As no corrective antidote is available, the filler is removed from the market. Bovine collagen was a very early injectable filler used in aesthetic arena. Different products emerged depending upon the collagen content and degree of cross-linking. Zyderm 1, based on non-cross-linking collagen, was designed for superficial dermis. The risk of collagen hypersensitivity reactions meant that a pre-testing was mandatory. जी बेटा। जी बेटा। ठीक है। ठीक। ठीक है, तो आप आपको रसीद आप अपनी ले आइएगा ना वापस। हाँ ठीक है। हाँ क्या ले आए? अच्छा ठीक है, ठीक है, ओके। Um, Xydem 1 is based on non-cross-linked collagen was designated for the superficial dermis. The risk of collagen hypersensitivity reactions meant that pre-testing was mandatory. This consisted of an intradermal injection of Xydem 1 collagen into the volar aspect of forearm and is evaluated after 28 days. An additional 1.3% of patients reported adverse reactions despite of negative pre-testing. Bovine collagen is no longer available in Europe and USA due to primarily to inconvenience of this prick test requirement and poor longevity compared with HA preparations. So now this is of academic interest only. Porcine collagen. The only porcine collagen in wide use was Evolens, introduced in European market in 2004 and withdrawn in 2009. There are two preparations available, Evolens and Evolens Breeze, used for nasolabial fold and for more superficial dermal injections and lip augmentation. The risk of hypersensitivity reaction to porcine collagen was not of clinical relevance. Porcine collagen has yellow color which is visible beneath the skin. And because of the religious issue, this kind of injection is not considered halal because of the porcine origin of the collagen. Human collagen. Human collagen used for cosmetic injections was derived from the natural collagen growth grown under controlled laboratory conditions and did not require pre-testing. Two products became available, the Cosmoderm, a non-cross-linked where a cross-link is Cosmoplast. Based on these trials, the durability seems to be inferior to other products, contributing to subsequent withdrawal of these products from the market. Then collagen stimulating fillers. PLLA was the first filler that postulated and showed collagen stimulating properties. However, now it is recognized that even HA is not completely inert and repeated injection seems to stimulate some naive collagen production. The direct comparative studies between the collagen stimulating products and HA filler for at least 12 months are needed and no good data currently exist as such to claim that which one is better. PLLA, polyl-lactic acid, is the only injectable filler with proven significant collagen stimulating potentials. The onset of action of PLLA is delayed and patient must be advised not to use it for immediate results. After repeated treatments, the long-lasting effects and durability are a major advantage over some of the other products. Another advantage is that this product will produce natural result and there will not be a complaint of overfilling. The manufacturer of Sculptura, which is the brand leader of PLLA, recommends that 3 initial treatment sessions each approximately 6 to 8 weeks apart. After that, the results may last for more than 2 years. You can reduce these number of treatment to two, and this is our general practice that we recommend two treatments 6 to 8 weeks apart, and usually the results are for 2 years. The product comes in the form of a powder and which needs to be diluted with sterile water, not the normal saline, but nowadays normal saline is also being used. But with the sterile water, it is diluted much easier. And the current recommendation is to dilute it with 9 ml of water with 1 ml of lignocaine, xylocaine. Before 210, studies on efficacy and safety of PLLA were based mainly on the treatment of HIV patients with drug-induced lipoatrophy, which is caused by the heart treatment. Importantly, correction of PLLA lasted for more than 13 to 25 months, which is why patients prefer this product. However, the grade of correction that could be achieved was less in PLLA compared with HA. As I have told you, that it will produce some natural results and there will not be overfilling. So the filling effect of PLLA is 0.66 to 0.85 as compared to the hyaluronic acid filler in 6-point check scale. Papule and nodule formation is the main adverse effect of PLLA, and that's why you need to massage the area quite often. It is said that you have to massage it for 3 times a day for 3 to 4 minutes for 3 to 4 days. There is indirect evidence, and this nodule formation depends upon the dilution of the filler used. There is an indirect evidence that papule and nodule formation can be reduced when higher volume of dilution is used. And this is correct as far as our experience is concerned. In few patients, the formation of large nodule may indicate an exaggerated immunological reaction to the product. In most patients, nodule formation is temporary and will decrease over time, so no aggressive treatment is required. Then the polycaprolactone or PCL fillers. Elance is the brand leader of this category and approved for use in European market in 2009. It is composed of PCL microspheres in aqueous carboxymethyl cellulose gel carrier. So the initial effect of injection is by this carboxymethyl cellulose gel carrier, and the prolonged effect is with polycaprolactone microspheres. It has a collagen biostimulating properties. In a single trial, PCL is shown to be slightly superior to Restylane Perlene after 12 months. There is no antidote available, so in case of overcorrection or an adverse event, the treatment options are limited. Then calcium hydroxyapatite as the biostimulator. Calcium hydroxyapatite is sometimes advocated as biostimulating filler. However, evidence is scarce. But nowadays, many aesthetic physicians are using it as biostimulator. In a small retrospective study for mid and upper face rejuvenation based on 40 patients, use of diluted or hyperdiluted kaha for skin tightening results are promising. A randomized controlled trial, for instance, comparing diluted or hyperdiluted kaha with PLLA would be very welcome in guiding the clinical practice. And as far as the dilution is concerned, it is usually 1:2 or 1:3 dilution, and it is diluted with normal saline. Non-biodegradable fillers. In Europe and USA, there are only a few non-biodegradable or permanent fillers currently available. Several products were removed from the market due to very severe adverse reactions, both acute and delayed, which negated any potential advantages. There are no antidotes available for these fillers. The silicones. The medical grade silicone is clear, oily, colorless liquid composed of long chain of polymerized dimethyl siloxane. There are several methods to inject this product, including the microdroplet technique. The fluid silicone is injected into the dermis as 0.1 ml microdroplets at 1 mm intervals, with preference for undercorrection. In general, the inflammatory reactions surrounding the injected silicone is self-limited. However, the extent of reaction is not predictable and in some cases may be quite severe. Local adverse reactions include infections, migration, extrusion, ulceration, and silicone granuloma formation. Once these complications occur, removal of injected silicone is quite difficult, and methotrexate therapy was used as a good alternative. Polyacrylamides. There are several polyacrylamide products in the market, but only Aquamid is available in Europe and USA. It's composed of 97.5% water and 2.5% cross-linked polyacrylamide. And it is used for volume correction and injected deeply using the subcutaneous tunneling technique. It is also used for breast augmentation and for facial treatments. No long-term adverse effects were observed in 3.9-year study. However, when adverse effects do arise, they may be severe and challenging to treat. In a large study comparing PLLA with polyacrylamide in HIV-positive patients with therapy-induced lipoatrophy, more severe inflammatory reactions are seen with polyacrylamide group. So again, this is not a preferable injection. Then polyalkylamides, marketed as bioalkamid, consisting of alkylamide group network approximately 4% and water 96%, into preparation of different viscosity indicated for lip and facial augmentation. The author of this text concluded that prevalence of these reactions was unacceptably high and the use of product is not recommended. So this product is not available in European market nowadays. Multiple substance products combination fillers. A fixed combination of polymethyl methacrylate or PMMA and bovine collagen, known as Balafil, formerly Arterial, was introduced at the end of 1980 and is the oldest available combination filler. PMMA beads are suspended in a solution of 3.5% bovine collagen as a carrier and 0.3% lidocaine for anesthetic effect. When the collagen absorbs over a period of 2 to 3 months, the PMA spheres becomes encapsulated by fibrotic material and remain permanent in the tissue. The Balafil is meant to be injected in lower third of the dermis and the material should not be injected superficially. Overcorrection is not advisable, however, second implant may be necessary after 3 months. The Balafil artificial nodule formation was the most common reported complication. As the product is permanent, the adverse reactions such as granuloma formation may develop years later. These granulomas are foreign body granulomas. Then hydroxymethyl methacrylate and ethyl methyl methacrylate microspheres suspended in hyaluronic acid. The HEMA and ethyl methacrylate microsphere suspended in HA is available in Europe as Derma Life from the end of 1990 till 2007. The product consists of 40% bacteria-derived HA and 60% acrylic hydrogel particles. The product has the ignominious distinction as being the derma filler product associated with highest risk of adverse reactions, primarily the nodule formation, but also abscess and ulceration. So the product is withdrawn from the market and no longer manufactured. The common injection errors. Now we are done with the different type of fillers. We will now discuss the injection errors and the complications. Treatment with injectable filler is generally a safe technique if administered by a properly trained practitioners. So, untrained or half trained practitioners should not attempt this mode of treatment. However, the adverse reactions or injection mistakes may occur from the hand of experts. General error. First is using the fillers with no antidote. Fillers with no antidote pose a challenge when they are accidentally injected into the intravascular spaces as they cannot be dissolved emergently. Slowly biodegradable or permanent filler products may remain implanted for years or even permanently. The patient's immunological reactivity may change over time, result in delayed adverse reactions such as large granuloma formations. Currently, there is no treatment or antidote to degrade a non-HA based biodegradable or permanent fillers available. Using products without good clinical data. The use of products in absence of good clinical data increase the risk of early adverse effects such as abscess formation. This is true for most of the Chinese and Korean products which have flooded our markets, and you should only use those Korean brand fillers which have proper say distributors available and which have a web page, website, and which you can read about them. So only use those Korean brands. Most clinical trials are restricted to use of nasolabial folds. Other areas such as lip, glabella, temple, forehead, and infraorbital hollows are less well understood. So this is true for most of the fillers. The injection errors. Inadequate aseptic techniques before the injection. So um, always take care of the asepsis. Early inflammatory reaction and abscess formation may be a consequence of non-sterile injection. Disregard and lack of respect for anatomy. Fillers are increasingly used for volume augmentation in all kinds of patients. To avoid an aesthetically displeasing outcome, for example, asymmetry, or more serious events like arterial occlusion, a good understanding of both surface and deep facial anatomy is required, especially the vascular anatomy. This includes not only the layers of the skin and subcutis, but muscle, fat compartment, ligament, nerve, vessels, and underlying bony structures. So, without a good knowledge of anatomy, no one should attempt filler injection on the face. Using deep injection fillers too superficially. The injecting a filler which is designed for deep injection, that is high G filler, very superficially is a common operator dependent error. A high G prime filler are those used for volumizing, but if injected superficially, it will result in unsighted bumps and sausage-like appearance. In case where HA is injected, can be easily corrected by dissolving it with high hyaluronidase. Injecting too much volume in one session. A conservative, less is more approach is safest and aligns with natural, gradual rejuvenation strategy which most patients desire. Large amounts, for example, more than 3 ml per site, when treating the cheeks, will lead to very visible change and an unsightedly overextended face. Injecting under timely constraints. Adverse events occur more frequently when injectors work under time constraints. So filler injection is not a thing of hurry. So injecting in relaxed manner will benefit the patient and injector alike. Filler should be injected slowly in small amounts. No one injection should be more than 0.1 ml. Overcorrections, asymmetries, hematoma, and probably arterial occlusions is probably because of increased injection pressure and which occur less often. Similarly, caution must be used prior to special occasions, for example, wedding, particularly in novice patients with plenty of time allowed. So, you should not inject in such patients at least 2 weeks prior to the main event, so that if bruising occurs, there will be a time for it to settle and other necessary corrections and touch-ups can be done. The adverse reactions and their treatment. No injectable filler is without potential risk of adverse reaction. The key issue to consider is how high is the risk and how can it be mitigated. Assessing and reducing the risks. To accurately assess the following data is required: the number of adverse reactions and total number of patients treated. For most injectable fillers, this information is not available. Data on number of adverse reactions are dependent on adverse event reporting, and there are serious lapses in clinical reporting of these events. The total number of patients treated can only be estimated based on the volume of products sold, but in the market there are many products that are purchased from number of illegitimate and black market sources. So the scientific data or tabulated data for these adverse reactions and their treatment is still limited and is more of a hearsay. Friedman et al. Reviewed the data of unwanted effects of Restylane range of HA products reported globally between 1999 and 2000. For 1999, based on 144,000 treatments, the incidence of adverse event is calculated as 0.15%. While in 2000, based on approximately 262,000 treatment, the incidence reduced further to 0.6%. The potential adverse reactions. In general, the adverse reactions are classified as acute, subacute, or delayed based on the time onset of the injection. Acute reactions occur immediately after injection or after a few days. This includes hematoma and arterial occlusion. The subacute reactions generally encompass reactions that occur weeks after injection. So all the nodules, bumps, abscesses comes under this. And in the delayed reaction, we find granulomas or biofilms. Reaction can also be grouped according to the clinical diagnosis. In the most severe adverse reactions are the arterial infarctions, hematomas, abscess, nodule formation, followed by immunological reactions like granulomas. The management plan for any adverse event is depending upon the type of filler and type of reaction. Abscess are usually acute and subacute, although cases occurring after several months or year are reported. If abscess is fluctuant, it should be drained and bacterial microscopy and culture undertaken with consideration for atypical mycobacterium followed by administration of appropriate antibiotics. Nodule formation indicates an exaggerated immune response and is most common adverse reaction to all fillers. Some researchers advocate that biofilm, a low-grade bacterial colonization, may play a significant role in nodule formation by triggering the immunological reaction. So in the last year, in cases of inflammatory reactions towards permanent filler, methotrexate therapy is used in a couple of case series with good clinical success. Treatment approach for immunological response nodules after HA injection. The first line treatment is hyaluronidase injection. If HA filler is used, inject hyaluronidase around the nodule. Do not forget that bovine hyaluronidase might elicit an allergic reaction. The second line is immunomodulatory treatment. That is, you can inject intralesional steroid or 5-fluorouracil or start oral steroids. And sometimes doxycycline may be used for inflammatory role as an anti-inflammatory role. Be careful of steroid atrophy. Do not inject high concentration of steroid intralesionally. If you have to give oral steroid, then you can give 60 milligram of prednisolone for 2 days, then 40 or 50 mg for another 2 days, and reduce it to 20 mg for 2 days. Third line would be surgical treatment. If none of the above treatment is effective, then surgically excision is to be done, but be aware of scar formation. The treatment approach for immunological response for non-HA based filler. So since hyaluronidase is not effective, the first line will be immunomodulatory treatment. So we can try the injectable intralesional steroid and 5-fluorouracil and oral steroids or oral doxycycline. And sometimes, if nothing works, then methotrexate 10 to 15 milligram per week with folic acid supplement. You have to be careful of the steroid atrophy while giving intralesional injection. If prednisolone is to be given, it is given with 60 mg and reducing by 20 mg after every 2 days. Methotrexate is shown to be effective in granuloma formation. Fumaric acid tablet is also found to be effective, but this drug is used for psoriasis and show some effects on sarcoidal granuloma formation. So the third line treatment becomes the second line treatment for immune non-HA based fillers. This is excision or laser. So among the lasers used, diode and CO2 lasers will create drill openings in the granuloma and filler is extruded out. Arterial occlusion is the most fearsome complication of dermal fillers, considered as a medical emergency as arterial occlusion due to direct embolization or compression. This is an acute event accompanied by immediate pain and blanching at the area of occlusion. The highest risk injection sites are glabella and forehead, nose, and nasolabial folds. There are several reports of blindness due to arterial occlusion following filler injection in these areas. If HA is the culprit, hyaluronidase should be immediately injected. And it should be flushed, the area should be flushed with lots of hyaluronidase. Injection of hyaluronidase is most effective within 60 to 90 minutes of the occlusion. Animal studies have demonstrated that occlusion is reversible in a 4-hour period only. After 24 hours, the effect is less reversible. The expert consensus recommends treatment of hyaluronidase even after 24 hours. Injection should be repeated until the pain subsides and occlusion resolves. In case of acute blindness after HA injection, patient need to be given immediately hyaluronidase around the treated area. The retrobulbar injection of hyaluronidase is not found to be helpful, and you should all learn to inject hyaluronidase in the supraorbital notch. In case the patient should be seen in emergency, and in any case, patient should be seen in emergency by an ophthalmologist. So, the treatment approach for different cases of arterial occlusion, if there is blanching and severe pain or loss of vision, which is the extreme case, stop the filler injection immediately. Then, sign of cutaneous occlusions, inject hyaluronidase around the injected area in the course of affected artery, repeated if necessary or daily for several days, unless the pain subsides and area restores to normal circulation. Although hyaluronidase is most effective in 4 hours, should always be used in vascular occlusion even when the diagnosis is late, that is, even after a few days. If there is sign of cutaneous occlusion due to non-HA based filler, apply topical trinitroglycerine to enhance the dermal flow. Loss of vision. In case of HA, inject hyaluronidase immediately where the original filler is injected. And I have already mentioned that try to learn injecting hyaluronidase in the supraorbital notch. In conclusion, the treatment of adverse reactions to dermal filler injection remain a significant challenge. Nevertheless, adverse reactions appear to be diminishing over the years, particularly when increased popularity of biodegradable products where the risk of persistent sequelae is low. And furthermore, the efficient training courses and workshops are also helping in improving the skills by the new injectors. Fillers and different skin types. There is no known difference in case of immunological reactions between different skin types. Therefore, the rate of adverse reactions can be assumed to be quite similar, independent of skin type. The darker skin may react with most post-inflammatory hyperpigmentation to inflammation. Otherwise, all the other adverse effects are of equal proportion. And efficacy and safety are similar compared with fairer skin. This brings me to end of this talk. I am sorry for slight disruption, and I picked up a call. So I hope you would forgive this. Thank you very much, and hope to see you soon with another edition of my talk. Goodbye and have a good day.